Recording started.
Hi, good afternoon, everyone, and thank you for participating in today's webinar. I would like to pass on the phone now to our moderator for today, John Auerbach. John, go ahead, please.
Thank you very much. Welcome, everyone, and thank you for joining us today for this webinar on breaking through barriers to reach teens. We'll be looking at policy and practice with a particular focus on STD services. Today's webinar is part of an ongoing effort by several organizations to encourage the active consideration of and steps towards integrating STD services into primary care settings as part of the changing circumstances for local, state, and national governmental public health. My name is John Auerbach, and I'm a professor at Northeastern University and the director of the Institute on Urban Health Research and Practice, and I'm also a former state and a former city health commissioner. We've received funding from the Association of State and Territorial Health Officials to assist local and state health departments to consider stronger linkages between public health and primary care. And these efforts are occurring in conjunction with the National Association of County and City Health Officials, or NACCHO, with the National Association of Community Health Centers, and also with the National Coalition of STD Directors. All of these efforts have been generously supported by the Centers for Disease Control and Prevention. And we want to thank ASTHO, CDC, NACCHO, and the National Association of Community Health Centers and the National Coalition of STD Directors for your support. Today's webinar follows activities that have taken place over the last year. Last year, 10 teams from across the nation were formed to assist in the consideration of the optimal ways to integrate STD and other traditionally provided public health services into primary care practices. And these teams represented both local and state health department officials, as well as leaders from community health centers and from state primary care associations. They participated in a survey, met in Atlanta for a 2-day meeting last year, and also were surveyed after that meeting about the progress that they've made. And they helped us to identify additional needs for training, technical assistance, and support. We identified 2 topic areas as important for webinar presentations, one of which we presented on earlier this week. That was taking advantage of the emerging efforts to tap health information technology for the management of STD screening and treatment. And the second one we are addressing today, and that's taking steps to guarantee confidentiality and access, particularly for adolescents, in the provision of STD services in primary care, with a variety of alternative policy and programmatic approaches. For both webinars, we've invited the members of the 10 teams that I mentioned, but in addition, because there's so much interest in these topics, we've invited other STD directors, health officials, community health centers to join this call, and at this point we have close to 100 people who are participating. Now let me share with you the format for today's call. The call will last until 2:30. We'll hear from 2 outstanding speakers who are nationally recognized and widely respected experts. After each presentation, we're going to open the floor for questions, both written and verbal. So as you're listening to the presentations, please do consider the questions that you'd like to ask or the comments you'd like to make as soon as the presentations are over. And at that point, the operator will offer instructions about how to offer your question. But please be prepared to jump in at that time. I'm delighted to introduce our first speaker. She is Abigail English, and she's the director of the Center for Adolescent Health and the Law in Chapel Hill, North Carolina. Her center is a nonprofit legal and policy organization that works nationally to promote the health of adolescents and their access to comprehensive health services, with a focus on addressing issues of consent, confidentiality, and financial access to services. Miss English has worked on legal and policy issues affecting adolescents' access to health care for more than 25 years, and she's participated in major litigation affecting the legal rights of children and adolescents. She's authored numerous publications and lectured widely to professionals who serve youth. Ms. English will present a legal and policy framework for thinking about confidentiality of adolescent health services, specifically STD services. And while there's not a perfect solution, Ms. English will describe initiatives going on in 5 states to address the issues related in particular to the explanation of benefits and confidentiality. Thanks very much for joining us today, Ms. English.
Thank you, John, and thank you very much to ASTHO and Northeastern and all of the other groups that have co-sponsored this initiative that you've been working on over the last couple of years, and to CDC for funding this work. I'm really pleased to be with you and have a chance to talk about these issues today because I think they are very important ones in reaching adolescents and making sure they get the health care that they need. I'd also like to quickly thank 2 colleagues at the Guttmacher Institute, Rachel Benson-Gold and Elizabeth Nash, with whom I worked in 2012 on a report that I'll be talking about later in the webinar presentation. But now I'll just jump right into what I plan to share with you this afternoon. And I'm going to go through rather quickly some background issues just as a refresher and to make sure we're all on the same page as we delve into some of the newer policy development. So I'll talk a little bit of a reminder as to why confidentiality is important and what some of the challenges we've been facing for years and are still facing in trying to protect confidentiality, what some of the implications are of the Affordable Care Act, an overview very quickly of what the existing confidentiality protections are in place under both federal and state law, and then what the existing disclosure requirements are primarily under state law and to some degree under federal law. And then having set that stage, I'll dive into talking about what's happening in several states in the effort to protect confidentiality in the context of financing of health care and insurance, and close with some of the challenges that are ahead and that we need to meet in order to achieve our goals here. So I think probably everyone on the call is aware that we have decades of research findings that have documented the ways in which privacy concerns related to specific health issues are significant: mental health, substance abuse, pregnancy, and of course, for today's call, particular importance of sexually transmitted disease. These privacy concerns affect all age groups, but we're concerned today about adolescents. But some of the same factors are in play with young adults, with domestic violence victims, and even with other adults in general. And the concerns about privacy and the need to protect confidentiality have important implications for individual health because they limit the use of both health care and insurance coverage to pay for that care, and also, of course, have public health implications in terms of increased risk for multiple health problems. So we need to just keep that array of research findings in our minds as we look to what the solutions might be for protecting confidentiality. Finding ways to pay for health care and also to protect confidentiality is not a new problem. The American Medical Association in 1992 issued a report of its scientific committee on adolescent health care and highlighted the issue of the difficulty of adolescents utilizing health insurance coverage that they had to receive care that they needed on a confidential basis. So we have seen this problem really for decades. And it involves, solving the problem involves clarifying the roles of private payers and of public payers, and finding ways to avoid unnecessary burdens on public health sites and public health funds. So part of the agenda has to be making sure that insurers who receive large sums of money in the form of premium payments meet their responsibility to pay for the services that are included under the policies that they issue. And that is, it turns out, a much taller order than we might have originally anticipated, but it's an essential component of encouraging adolescents to seek essential health care, including sexually transmitted disease screening and treatment. It's also essential in finding ways to allow healthcare professionals to meet not only their obligations to provide appropriate medical care, but in doing so to observe the ethical standards and requirements that apply to their professions. So as we move into the implementation of the Affordable Care Act, we have this backdrop of wanting to find ways that individuals who have insurance and will be gaining insurance in the coming months and years to be able to use that insurance not only for care in general, but also very specifically for care, including STD services that they need on a confidential basis. We are seeing already more individuals with insurance as a result of the Affordable Care Act. We are seeing expansion of coverage dramatically in Medicaid in the half of states that have expanded Medicaid. And we're also seeing significant addition of individuals with private insurance, both through the exchange plans, but also prior to that with numerous young adults being able to stay on their parents' plan. So we have a lot more adolescents and a lot more young adults who are insured, along with the ones who have had insurance previously. The Affordable Care Act has one extraordinarily welcome provision in it, which is that it guarantees access to preventive services without cost sharing in private health insurance plans. And that will become significant as I talk about what some of states are doing to try to protect confidentiality. So let's keep that element of the ACA in mind. There are also some kind of questions that are arising with the advent of the ACA, and that is, do we even really need a public health safety net anymore? You know, if everybody's going to have insurance and they have access to preventive services without cost sharing, why do we need a public health safety net? Well, I don't think I need to tell the people on this call why we need a public health safety net, but that is a question that arises, and it's one that we also need to keep in the back of our minds, because that public health safety net, whether it be STD clinics or Title X programs, has been one of the major sources of confidential care for adolescents in the past and continuing right now into the present day. But we can't just rely on the public health safety net, and we need to find ways to hold the feet to the fire of the private health insurance industry, and that involves looking at and resolving some of the tensions between insurance laws and confidentiality laws. So I'll just start into that discussion by quickly reviewing the sources of confidentiality protection in federal and state law. In federal law, obviously, we have the HIPAA privacy rule. We have the Title X family planning confidentiality regulations. We have confidentiality requirements in Medicaid, and we have the federal drug and alcohol confidentiality regulations. Under state law, we have a raft of laws, including those to implement the HIPAA privacy rule, and also laws that allow minors under the age of 18 to consent to their own care, and in some instances also explicitly require that the care is then confidential. There's some variation in the degree of confidentiality protection, but for our purposes today, we can think of minor consent laws as an important source of confidentiality protection that needs to be reconciled with the insurance laws. In addition, there are, of course, many other state laws related to medical information and medical privacy and medical records, and I'm not going to go into those today, but they are important, and they also have to be understood in relation to the insurance laws. So in 2012, the Guttmacher Institute, together with my center, undertook a study of the laws in all 50 states and the District of Columbia in an effort to identify ways in which the insurance laws might contain confidentiality protection for individuals who are insured as dependents of a family member on a health insurance policy. And we looked at several thousand laws, and we narrowed that down to about 500 laws that explicitly required disclosure in some way or another, either through explanations of benefits, through denials of claims and notices about denials of claims, or other requirements. We didn't find nearly as many laws that provided for confidentiality protection relevant to insurance, to the insurance claims process. We had hoped to find a larger number of the latter, but we found a few, and those few are the ones I'm going to talk with you about today, in addition to some that have been developed or enacted since we completed our study in 2012. We found, not surprisingly, that explanations of benefits are not only ubiquitous, but that they are explicitly required or at least presumed by laws in at least half the states. But the fact that there are only explicit laws requiring EOBs in half the states doesn't mean they aren't required in other states, because they are almost always required by insurance contracts, insurance policies, and of course by widespread practice. These are the documents that are typically sent by private insurance plans to policyholders, and those policyholders may or may not be the patient, and for the purposes of our webinar today, they generally are not the patient, because adolescents are virtually always covered under a parent's plan, not under their own separate plan that they've purchased for themselves. EOBs, and I'm not going to delve into this too much today, but it is important to note that EOBs are much less frequently used in Medicaid, at least for sensitive, in relation to sensitive services, which would include STD services. There is some variation in that among different states, and depending on whether we're talking about a managed care plan or some other form of Medicaid program, but it's much less of a problem at the moment in Medicaid as far as we've been able to determine. It's also important to know that the intention behind the development of these explanations of benefits was benign in large measure. It was to help prevent fraud, and it was to increase the transparency of the insurance claims process. And in fact, the EOBs and similar notices were advocated for by consumer advocates, and not just by insurance companies. So there are some unintended consequences of these EOBs, and I'm using the term EOB really to kind of cover all of the kinds of disclosures that occur through the insurance claims process. And one of the unintended consequences is to disclose information that is otherwise provided with confidentiality protection. And that's because the EOBs may contain a detailed description of the care provided, in addition to the charges that were submitted and the amount covered by the insurance and the amount not covered and the patient's remaining financial responsibility. But it's that detailed description of the care provided and the identification of the provider that can result in disclosure of information that it would be considered by the patient as confidential and that they would not want to have disclosed. I will mention that along with explanations of benefits, denials of claims are required not only by state law in essentially every state, but also by federal law under ERISA and under some new requirements pursuant to the Affordable Care Act, which require a diagnosis code and corresponding meaning and a treatment code and corresponding meaning. These denials of claims are frequently incorporated essentially into the EOB. So the insurance companies tend not to send one explanation of benefits and a separate denial of claim. They fold it into a single document, which is what we're all familiar with receiving. The state laws vary widely in terms of who the denial of claim is required to be sent to, and I've listed on the slide the wide variation, and I'll just highlight, for example, the insured, the beneficiary. That could be the patient. A covered person could be the patient, but subscriber could be the parent, who's the person who pays for and took out the policy. So there's a lot that has to be kind of parsed in any individual state's law in terms of who the forms are required to be sent to. So what we found in our study back in 2012 was that there were a few states that were beginning to experiment with, or at least adopt newish approaches to how to protect confidentiality in the context of the insurance claims process. And I've highlighted a list of those here on the slide, and they include New York and Wisconsin, which have either a statute or a policy saying that under certain circumstances an EOB does not have to be sent or can be sent directly to the patient. The provisions related to confidential care for STD care for teens, including in the billing process, were found in Connecticut, Delaware, and Florida. Those are not provisions specifically addressed to the insurance claims process, and I'm not going to detail them further here, but the report has citations to these provisions if anyone is interested in them. And I'm not going to discuss in detail either the Hawaii law that healthcare providers must inform an insurer when a minor without support, which is sort of a minor who is not living with their parents, requests confidentiality. We've tried to find out more about how that's being implemented in Hawaii and have not found much detailed information about that. And in Maine as well, there is a provision in Maine law that minors can refuse parent requests for an EOB or a claim denial, but we don't have a lot of detailed information about how that's actually working. What I will focus on, in addition to the New York provision that I mentioned already, are some provisions in Washington State, in California, in Massachusetts, and in Colorado that I think are particularly noteworthy and bear both examination as to how they're working in those states and also consideration for possibly extending them to other states. So I'll begin with New York, and I'm not going to read the language of the New York insurance law section. It's there on the slide, but rather highlight the fact that what New York has said is that health insurers and HMOs are not required to send explanations of benefits or EOBs when there is essentially full meeting of the patient's responsibility through the making of a copayment at the time of service, or presumably if there is no financial obligation on the part of the payment. And apart from that, the reimbursement is paid directly to the provider. I'm going to highlight one phrase in this code section because I don't think we know fully what the implications of it are, and I think it could be important, and that is the initial phrase that says, except on demand by the insured or the subscriber. And we need to think more, who is the subscriber, who is the insured? If the subscriber were the parent, could the parent still say, I want the EOB, even if all of the other criteria in the statute are met? But this at least is a framework within which certain STD services that would be covered fully by a copayment and would not result in any further financial obligation on the part of the payment or the policyholder could be provided, and an EOB could be waived or not sent by the insurer. In Washington State, they took a different approach and approached it from the perspective, really, of some requirements in HIPAA, in the HIPAA privacy rule, that allow for or provide for special confidentiality protections. And then Washington went somewhat beyond those requirements to add some other protections. Specifically, in terms of implementing HIPAA, Washington provided that insurers must limit disclosure of information when an individual requests it and makes a statement that they would be endangered by the release of or disclosure of that information. And one example that's given in Washington regulation is, for example, a spouse to prevent domestic violence, a spouse not wanting to have information disclosed in order to protect herself or himself from domestic violence. But it could also apply to an adolescent who believed themselves to be in some kind of jeopardy if their confidential information were disclosed to a parent. Washington went on to say that with respect to certain services that are often considered sensitive and needful of confidentiality, that the insurers had to limit disclosure relating to those services as well, including with respect to any mailing of appointment notices or calling the home to confirm appointments. That would apply in the case of health plans. Washington State has group health, which is more of an HMO structure where the insurer might be mailing appointment notices. That might not be true in other states. And then, of course, the mailing of a bill or an explanation of benefits to a policyholder. If the individual, in our case for today's purposes, the adolescent, makes a written request that not be sent. So that is quite an extensive and salutary provision. Last time I did some inquiring, there was not a lot of information available about how that was being implemented, but again, it bears further scrutiny. So California, quite recently, in October of last year, enacted a new piece of legislation that addresses this set of issues. And it's really important to keep in mind that California's new legislation was enacted in the context of a framework in California that has existed for some time. And I'll specifically highlight one aspect of that framework, which is that California has a fairly extensive set of laws allowing minors to give their own consent for health care. And it also has, which not every state does, have a set of laws that make it very clear, make it explicit, that when a minor can consent for health care, it is the minor who has the right to control the disclosure of that information. So that is the backdrop to what California did last fall in trying to address these confidentiality issues in the context of insurance. California, the first thing that their statute did was to explicitly incorporate certain HIPAA requirements into state law. Those were requirements already, whether or not they were explicit in state law, but the new statute makes them explicit in state law. And those are the ones that I alluded to in the context of Washington, which is that when an individual makes certain kinds of requests for confidentiality protection, the insurer is required to comply with those requests. And those are requests related to what are termed sensitive services in the California legislation, if there's a danger to the individual from disclosure. But the individual is not required to explain the nature of the endangerment. They just have to assert that they would be endangered. And the protections apply to individuals who are insured as dependents on a family member's plan, including both minors and adults under the age of 26, which of course has been a significant expansion of the insured population over the past couple of years. The other two states that have done something recently are Massachusetts and Colorado in quite different approaches to the issue from what was undertaken in Washington and California. In Massachusetts, the legislature passed a statute requiring the Division of Insurance to develop what was termed a common summary of payment form, which would essentially replace explanations of benefits. And last year there were some public hearings held on what that common summary of payment form should consist of, and a rather extensive advocacy coalition submitted comments for these public hearings to the Division of Insurance with 6 recommendations: that the forms should be issued to members instead of to policyholders, that the members should be able to access the forms through alternative means, in other words, not just by receiving it in the U.S. Postal Service mail, but perhaps on a cell phone or through other technological mechanisms. That the form should be issued only when there's financial responsibility on the part of the patient or the policyholder, that the forms should suppress diagnostic descriptions, should, as with California and Washington, allow members to request confidential communications, and should require the insurers to implement the form uniformly. I'm not sure that the final form has been issued yet, but there was a lot of work in the public health and public health safety net community in Massachusetts to put these recommendations together, and adolescents was one of the populations they were particularly concerned about. Finally, in Colorado, a new regulation has been issued which doesn't really address adolescents, but I thought it noteworthy enough to include it in this presentation, because it is related and it's relevant. The insurers under this new regulation are required to take some steps to make sure that the confidential health information, PHI is the term under the HIPAA privacy rule, of any adult child who's covered under the policy of a parent is protected. And that is building again on HIPAA privacy rule requirements. These confidentiality protections that are included in HIPAA to develop ways of communicating exclusively with the adult child who's the patient and not with the parent or the policyholder, and not to send that information to the policyholder parent without the permission of the covered adult child. So that's the approach that Colorado is taking. That could be extended to adolescents. It hasn't been in that state, but it's something that could be considered. So I'll just close by saying that we have a lot of work to do. We need to, first of all, make sure that the existing confidentiality protections that are already on the books in various states are implemented. That will require educating insurers, further educating providers, and educating beneficiaries. And I know there are some significant outreach efforts and implementation efforts going on, at least in California, with respect to their new statute that was enacted last October. And I would hope and presume that some implementation efforts are going on in some of these other states as well. We need to evaluate the effect of these protections. How far do they go and how successful are they at making sure that those individuals who need confidentiality protection get it without having to forego their insurance coverage. And we need to further explore some of the objections or assertions that insurers raise about legal impediments and technical impediments as reasons why they can't both protect confidentiality and meet their legal obligations without undue expense and technological changes to their systems. And finally, we need to identify and also refine new approaches to protecting confidentiality based on what we learn from the ones that are being tried so far, and whatever imaginative approaches we can come up with for doing an even better job in the future. So thank you very much for your attention, and I look forward to questions.
Well, great. Thank you, Ms. English, for that really informative presentation. It's terrific to have a summary of what's happening around the country and to clarify the information in the way that you have. Maria, who is the operator, will now instruct the participants in the webinar how they can either ask a question or write a question.
Thank you, John. To write your question, you may do so in the chat box on the left-hand side of the web room, or if you would like to verbally ask your question, please press #1 on your phone keypad. Thanks very much.
Thanks. So, Ms. English, the first question has come in from one of the participants in the call, Laura D., and she asks, what strategies have states like Washington used to make sure that young people know that they have the option of making a written request to limit disclosure for these kinds of services?
That's really an excellent question, and unfortunately I don't have a good answer for the question because when we completed our study of the laws in 2012, we did some informal interviews, telephone interviews with people in various states to try to find out what was being done to implement the few protective legal provisions we found, and we were not able to identify any sort of systematic efforts in the state of Washington. It is it is the case that individual providers and individual sites are taking some steps to inform their own patients, but not in a systematic way. I do know that the folks in California who advocated in favor of the enactment of their law last October are now very actively working to develop strategies to reach young people, in particular the adolescent population, to inform them that they have this right. And part of that will be informing providers so that providers can inform their patients, but part of it will also be using some of the new, the new electronic means of reaching young people more directly to educate them about their rights in this regard.
Thank you. Maria, is there someone waiting on the phone to ask a question?
Not on the phone, John.
Okay. So let me ask the next question. You mentioned that Medicaid programs are less likely to have the EOB. Could you talk a little bit more about that and maybe also address how would a state health department or a community health center find out what the policy is in their Medicaid program?
Great question, John. A few years ago, I don't remember exactly when it was, 2 or 3 years ago, the National Alliance for Adolescent Health did do a review of state Medicaid agency policies with respect to the sending of explanations of benefits, and the report of that review that they did is on the website of the National Alliance for Adolescent Health. And they found that with respect, and I think STDs was one of the major issues, that with respect to these sensitive health issues, a lot of Medicaid agencies had found ways to not send explanations of benefits that went to the family, that was enrolled in Medicaid. And I think it's really important to keep in mind that there are not the same exact laws applicable to Medicaid with respect to these issues, and that the contracts with Medicaid and between Medicaid and insurers are not exactly the same as with private insurers. So there are variations by state. I think the best thing to do for a health department or any other site in a state that was in a community health center that was interested in finding ways to address this in a similar fashion than their Medicaid agency had done would be to directly contact the Medicaid agency in the state and find out, sort of who's in charge of the Medicaid contracting. I would be happy to send you, John, a link to the report that I mentioned that was done a few years ago by the National Alliance for Adolescent Health, and maybe that could be sent out to your audience here.
Thanks. That would be great to have that link. But it sounds like if people Google National Alliance for Adolescent Health and Medicaid, would they probably get a copy of this report that way?
Yes, they have a list of their reports on their website, and it's fairly easy to find their reports.
Great. Well, another question has come in. This one isn't so much on the issue of the confidentiality and explanation of benefits, but does relate to adolescents' access to STD care. It comes from Jasmine D., and she asks, what can be done when faith-based medical facilities refuse to see minors for reproductive health services, even though they accept and bill for Medicaid and medical or other publicly funded family planning programs? I don't know, Ms. English, if it's fair to ask you that question, since it's a little bit off the topic of.
Well, it's a very important issue, and it is increasingly an issue as many systems are being purchased by religious organizations and operated by them. And so there's been a lot of kind of both legal and just kind of practice-based dialogue and concern about this whole question of making sure that young people can have access to, well, any age can have access to contraceptive and STD services in the context of faith-based settings. I think that the organization that has really done the most detailed and thorough work on this issue that I'm aware of is the National Health Law Program, and they have something called their Standards of Care Project, and that is that those standards of care are have specifically been developed to address this issue of delivery of reproductive health services in the context of faith-based settings. And so I would refer people to the National Health Law Program's website and the report that they've done in their Standards of Care project.
Thank you for that. Maria, anyone waiting on the call?
Not on the phone, John.
Okay. So let me ask, I'll just answer one final question that came in from Sierra P., and this is also a question that we received on Tuesday, and that was, will people that are on the call be able to get copies of the slides? And we are taping this webinar, and the tape, visual as well as oral, is going to be available on the ASTHO website. So it's the Association of State and Territorial Health Officials website. We'll post the webinar, including the slides. So again, Ms. English, just thank you very much for your work and your expertise and for providing us with this really helpful information today.
Thank you, John.
Our next presentation is by Dr. Gail Burstein. And Dr. Burstein is the Commissioner of Health in Erie County, New York, a position she's held since 2012. Prior to being appointed commissioner, she served as the medical director of STD services in Erie County, and she's a clinical professor of pediatrics at the University of Buffalo School of Medicine. Dr. Burstein, who also finds the time to see patients as a pediatric adolescent medicine physician, has been published in various scientific journals and co-authored position papers on sexual health policy for national organizations such as the American Academy of Pediatrics. Just as a little bit of background, the Erie County Health Department serves about 1 million residents and ranges from those who live in urban areas such as Buffalo to those who live in very rural areas in western New York. In addition to providing STD services, her department also gives technical assistance to private healthcare providers. This afternoon, Dr. Burstein will be describing a pilot that she conducted in her health department to improve chlamydia screening for adolescents through the promotion of an adolescent medical home model. Thanks very much, Dr. Burstein.
Thank you, John, and welcome to everybody. Good afternoon on this beautiful Friday, and I am happy to say that the weather is even gorgeous in Buffalo, New York, so it must be beautiful everywhere. So in the next 30 minutes, I'm going to discuss how local health, public health, was able to work with our community primary care providers on a quality improvement project to help them improve their chlamydia screening rates among their adolescent patients. So, as you all know, the local health department role is changing under our healthcare reform, and many local health departments' capacity for direct health services is diminishing. STD clinics across the country are closing, and with the Affordable Care Act, in many states, more people are becoming insured and accessing health care. While in many counties, local health departments are being advised or encouraged to get out of the service delivery biz, local health departments can fill an important niche by providing technical assistance for community providers who care for people at risk for STDs. So the question is, who are those people at risk for STDs? Well, we estimate that adolescents and young adults aged 15 to 24 years account for only about 25% of the sexually experienced U.S. population. However, this young 25% of the sexually experienced U.S. population accounts for 50% of all the 20 million new sexually transmitted infections each year. And of those 10 million new STI cases that occur each year among adolescents and young adults, 88% are from 3 infections: HPV, trichomonas, and chlamydia. Another way to look at surveillance data is on a population pyramid. So this is a population pyramid presenting 2012 reported chlamydia rates in the United States by age and gender. The x-axis corresponds to rates per 100,000 population, and the y-axis corresponds to age and groups. On the right-hand side are females, and the left-hand side are males. So you can see that by far the highest chlamydia rates are reported among adolescent and young adult females. So this slide is presenting data from the National Ambulatory Medical Care Survey of non-federally employed physician offices. It shows where adolescent females are being seen for health care. So along the x-axis is age, and the y-axis corresponds to the percent of females in each age group who are cared for by either pediatricians, family medicine docs, or OBGYNs. And you can see until about age 17, 18 years, adolescent females see pediatricians and family medicine docs much more than OBGYNs. And this young age group is when adolescent females are most vulnerable to STIs and pregnancies. So primary care providers, including pediatricians, are very important healthcare providers for adolescents. So it is so important that public health assists community primary care providers to deliver these essential healthcare services and routinize this care into their practices. Pediatricians and family medicine docs are really important healthcare providers for public health. And these are data looking at where chlamydia is being diagnosed in the United States in 2012. So you can see that, especially among females on the right, most chlamydia infections are being diagnosed by primary care physicians, which are the bars in aqua blue. So we know that adolescents are a priority population for STD control, and we know that adolescents who seek healthcare services usually goes to their primary care doc. So how do we as public health get primary care docs interested in chlamydia screening? What can we say to help them understand that this is a screening test that they should be performing routinely? So what we know is that in our community is that many primary care provider offices are in the process of becoming NCQA certified medical homes. So medical home serves as a centerpiece for nationally qualified assurance measures. Many health plans offer pay-for-performance medical home projects. So we thought we could offer to help primary care providers in our community develop an adolescent medical home. So they would be able to offer a comprehensive screening for all risk behaviors, including sexual behaviors, that should lead to chlamydia screening. So I know that some of you may not be familiar with the medical home concept. So the medical home encompasses the characteristics of pediatric care considered essential for all children. The American Academy of Pediatrics, or AAP, developed and has championed the medical home concept for decades. The medical home has received widespread national attention as a mechanism for ensuring quality in health care. So the medical home is defined as a model for primary care that is accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective. So since many primary care providers understand and fully embrace the pediatric medical home concept, we thought that they may be able to develop an adolescent medical home. So the question is, how does an adolescent medical home differ from a pediatric medical home? So we thought an adolescent medical home provides comprehensive and confidential adolescent preventive health care services. So the rest of my talk, I will describe our project to improve primary care providers' chlamydia screening practices by helping them to create an adolescent medical home. So our target population was adolescents presenting for preventive health care visits between the ages of 14 to 21 years. And in this pilot, we worked with 3 diverse Western New York State private pediatric offices. We worked with 1 large suburban office that had 6 physicians and 6 nurse practitioners, 1 mid-sized suburban rural office that had 4 physicians, and then 1 small urban office that had 2 physicians. So first, we provided training on our quality improvement tools, and then we conducted a quality improvement project with the offices using the PDSA cycle, or the Plan, Do, Study, Act model. So the Plan, Do, Study, Act cycle is a 4-stage rapid cycle quality improvement strategy. So for Plan, providers identify an opportunity to improve and plan a change or test how something works. For Do, they carry out the plan on a small number of patients. The test period may be as short as 1 day for small PDSA cycles, but we used a 2-month period. For Study, they examined the results. They asked, did they achieve their goals? And for Ask, they used their results to make a decision, incorporate changes into their workflow, and establish future quality improvement plans. So the data we presented to the pediatric officers were collected from the patient questionnaires that included data on the patient's risk profile and provider actions for chlamydia screening. And then we discussed possible office systems changes to improve chlamydia screening in each of the offices. So we gave each of the offices tools to facilitate the delivery of comprehensive, confidential adolescent preventive health care services. So these included a brief confidential questionnaire, which I alluded to earlier, that was used to assess high priority risk behavior categories, including sexual health. It consisted of 16 questions that were validated and at a very low reading level. We also provided providers with a letter to parents that explained the reasoning and the need for provision of confidential adolescent health care services. We provided the office with information about ordering relevant health information brochures. We gave the provider a list of local mental health and substance abuse providers. And then we also provided a teen and parent health websites in a brochure form and encouraged the offices to post these information on their websites. So let me run through some examples of the tool so you can see them. So first, as I alluded to earlier, was this confidential health survey for adolescents. So again, this is a brief questionnaire. Here's a picture of the questions, just 16 questions, very low reading level, validated questions that ask questions about all health behaviors and included a couple questions on sexual behaviors. So actually the providers loved this because it saved them a lot of time because they didn't directly have to ask the questions themselves or and then also feel uncomfortable about asking these questions. So they just gave the nurse to to give the patient this questionnaire to complete in in a confidential space. Usually it's when the nurse took the patient back for vital signs, they would ask the patient to complete the questionnaire. But unfortunately, we did this study when most of the offices were just getting their EMRs going, so they didn't really have, weren't able to rely on EMRs. So we had to use the old bubble scan form. So this is a picture of what the patients, actually completed with these bubble forms, and then we, scanned in the forms to get their answers. And then at the end of each of these questionnaires, there was an area for the providers to report actually the services they provided. And so we asked the providers if they asked them to report if they ordered a chlamydia test, and if they did not, we asked them to relay why they did not offer this test. So we also gave the offices a letter to parents, and this was in a Word document, so the providers can personalize it. They could put their office name and logo on it, explain the services that the office may or may provide. If there was a service listed they didn't provide, they could just, it was in a Word document, they could just delete that line. It explained what the confidentiality practices were in the office, and that the parents should expect that they would be asked to leave the room for a short time during the physical exam to give the adolescent patient some private time. They explained why they did that. We also took from the CDC's Youth Risk Surveillance Behavior Survey a survey of just the different prevalence of morbidities of different risk behaviors, and we put that in the questionnaire so parents would understand that there's a lot of risky behavior occurring in their state. And then we explained what the New York State minor consent laws are, and just tried to emphasize that this is routine, that the office did this for every patient. And what the offices found is that when they gave the families this letter, either ahead of them coming to the visit or when they registered for the visit, the families really accepted these confidential services. Parents never complained about leaving the room, and they were really set up to expect that the adolescent would have some confidential time, and that there would be confidential tests ordered, like a chlamydia test. So if they received notice about this on the explanation of benefits, they weren't surprised, they were expecting it. And the office's experience is that they didn't have any parents that were angry about this. Whereas, before they had this letter, parents would be upset because they would be surprised that all of a sudden they were asked to leave the room when they hadn't before, and they were upset because they were surprised, or they were upset when they saw a chlamydia test on the explanation of benefits because they hadn't been expecting it. So this really set the parents up to expect these confidential services, and they were not surprised or upset. So then, we also pulled from, different, good adolescent healthcare provider websites, just tips for the offices to help them protect youth confidentiality, just some systems changes that they could make in their office. It included a checklist of things that they could do in all different aspects of their office, from the clerk to the billing person, the medical assistant, and the nurse, just to get all their ducks in a row. And there was also included that it was a handout to preferred riders, just helping them, giving them a dialogue of what to say to parents to make them feel comfortable asking them to leave the room sometime during the physical exam. We also gave them some resources around billing and coding for confidential adolescent healthcare visits. So again, we gave them a list of, different types of CPT codes that they could use, and when not to use them. We also gave them, a laundry list of the most commonly used CPT codes for billing for adolescent services. And then we gave them some kind of basic tenets around billing for confidential care. And then we ran through a few examples, a few vignettes, so they could see how this could be applied. We also gave them copies of some confidential health information that was available in the public domain. So the Physicians Reproductive Health have these minor access cards for 12 states. Fortunately for us, includes New York State, which really spells out what healthcare services minors have the right to consent for in New York State. And this is available free on the physician's website. And then in New York State, our American Academy of Pediatric District put together a Teen Healthcare Bill of Rights. So this is really targeted for the adolescents. You can see it's colorful, it's in large font, very low reading level, just like one message on each page. So adolescents can understand, what they have the right to consent to in New York State, and and what is confidential and what could possibly be disclosed. So again, we, help them think about how to be a responsible patient, what their responsibilities are on the patient side. Again, we warn them, when providers may have to disclose confidential information. So it's not always confidential. And then I've worked with other adolescent healthcare providers across the country to put together a brochure of adolescent health websites, and most of these had portals for parents too. They, all gave information, good, valid information around sexual health, but many gave information around just general adolescent health. And if you can see, many of these are sponsored by academic institution or government entities. So we also gave them a monograph that was developed by the National Chlamydia Coalition called Why Screen for Chlamydia, and it just really is a great tool to walk offices through, and not just how to get geared up to provide chlamydia screening and treatment services, but really in general you could use this to provide all is a pathway to provide all confidential adolescent sexual health care services. So you can see from the table of contents, it runs through the whole gamut of why it's important to provide this screening, and how you make systems changes in your office to get geared up to provide confidential, adolescent-friendly healthcare services. Explains, again, about the tests, which tests you should use, who you should screen, and then, really walks the providers through, again, how they need to set up their office to be youth-friendly from the time the adolescent walks into walks to the door of the clinic or the office until, unfortunately, the provider may have to contact the patient and inform them of their positive chlamydia test result, think about how to get them treated, and counsel them about expedited partner therapy if that is available in their state. So we also encourage the participating providers to put this information up on their website, because that was something that providers were encouraged to do as part of a medical home. So this is one of the pediatric practice we worked with. So they put their confidentiality statement up on their website. They had an adolescent health tab. And then they also put a link to some of the websites that were in the brochure. So again, that patients could go to their office's website and get all this information easily. So what we did with the study is that at the 3-month office visit, we provided the offices with feedback on their patient population risk profiles from the adolescent questionnaire responses. And we also provided the providers with feedback on what they did for chlamydia screening, HIV testing, sexual health, and contraception counseling for patients who reported being sexually active. We discussed possible office flow changes to enhance routine chlamydia screening, and we also offered the offices additional adolescent STI and contraceptive management training to interested staff. Then at the 6-month visit, we did pretty much the same thing. We also discussed if they had any success implementing the office flow changes that they had agreed to at the 3-month visit, and opportunities for improvement, and then we also solicited feedback on the entire project. So let me just share with you the results, and then for brevity's sake, I'm just going to share with you the results on the chlamydia screening. So, again, this is the data on the office's chlamydia screening. So in this table, we're looking at the chlamydia test ordered among sexually experienced adolescents in each of the offices. So in the first column are the results for the small urban office. In the middle column are the results for the large suburban office. And on the right are the results for the mid-sized suburban rural office. So the first row shows the number of patients who are eligible for chlamydia testing because they reported that they were sexually active on their questionnaire. The middle row are the percent of eligible female patients who had a chlamydia test ordered, and the last row is the proportion of eligible male patients who had a chlamydia test ordered. And so for each office, we presented the data at the 10 and the 20 week of the study period. So let's focus on the female patient test results. So you can see that the small urban office and the large suburban office did have some improvement, but they really couldn't get their numbers high enough to where we all wanted them to be. And so during the study period, the mid-sized suburban rural office never really embraced the chlamydia screening concept. They thought they were doing a great job just asking the patients to complete the behavior questionnaire, and that they thought that was really good enough. So at the 3-month follow-up visit, we really found that each office had its own issues to chlamydia screening. So at the 3-month visit, we found that the small urban office just did not understand chlamydia screening recommendations. They didn't understand that they were supposed to screen every sexually active adolescent and young adult. And then they also didn't understand that the health plans would cover this test. In the large suburban office, chlamydia screening we found was really provider dependent. Remember, they had 6 physicians and 6 NPs, and not all the providers bought into the concept of routine chlamydia screening for sexually active adolescents. So the mid-sized suburban rural office had several issues. First, the providers believed, again, that the point of the project was to use the questionnaire, and they really were not interested in chlamydia screening. They thought that they should refer those sexually active patients to a GYN outside the office. Also, they had a structural issue. The only patient toilet was located in the waiting room. So a patient would have to leave the exam room and go out to the waiting room if the provider decided to collect a urine after the patient was already in the exam room, which was a problem because, remember, developmental issues, adolescents think that, they have this imaginary audience that everybody's looking at them, and nobody wanted to go back out in the waiting room to provide a urine specimen. So at the 6-month follow-up visit, the small urban office really wanted to continue using the project tools, and they planned to develop their own chlamydia screening QI project as part of their NCQA medical home certification. So they really wanted to take this on. The large suburban office also planned to continue using the project tools, but they realized that the only way that all the eligible patients would get a chlamydia test was to create an office policy for the nurses to send a chlamydia screen on all females who are 15 and up. So they decided to send chlamydia tests on all females, not just sexually active females or females who self-identified as being sexually active, because they were concerned that parents would suspect sexual activity if they just sent these tests on females who confidentially reported sexual activity. So they said that in order to preserve adolescent confidentiality, they had to send chlamydia tests on everybody. So the mid-sized suburban rural office also planned to continue using the project tools. And we reported to this office that all the other offices in the study were chlamydia screening and that they were the only office not following this practice. So we tried to guilt them out. We also reminded them that chlamydia screening sexually active females was an American Academy of Pediatrics recommendation. So since they didn't want to be different from their peers, they didn't want to be outliers, and because they were pretty active in our American Academy of Pediatrics chapter, they decided to try to routinely screen all sexually active females after the 6-month visit. So they developed actually an office policy that all females would get a urine cup from the receptionist when to collect a urine specimen when they registered for the visit. so they could use the waiting room bathroom. So all the female patients provided a urine specimen, and at all the well child care visits, and so this would not raise any suspicions from parents or anybody because everybody had a urine specimen collected. And so they also, again, this time were, incorporating EMRs into their practice. And so they decided to add an alert into their new EMRs for females who are 15 and up, so make sure that a urine specimen was collected at all the well child care visits. And if a patient was not sexually active, they realized they could just easily discard the urine, so it wasn't a big deal. So let me go over some lessons we learned from this pilot project. So first, the health risk survey was an important tool to initiate confidential services. The primary care providers really liked these concrete tools. They were easily incorporated into their practice. They wanted something that would help them get the job done. Also, providing feedback on each of the office patient populations, risk profile, and the primary care provider's actions was essential because, most providers overestimate the job that they're doing, and they all overestimated proportion of, especially of females, that they ordered a chlamydia test on. So we also found that the on-site office visits were very important and worked best when they were conducted by the same medical specialty provider. So I'm a pediatrician, so I went out to these pediatric offices. So, they felt like they were talking to a peer, and, they weren't, being instructed, how to conduct their business by, some mid-level or a nurse. And, it was really more of a peer-to-peer interaction. So ideally, we found that these visits would be conducted also by a provider that had established relationship already, because many private community providers are wary of the health department. They think that we're going to slam them from not complying for some rules, where really our role is to help facilitate them doing a better job with population-based health and public health. And so fortunately I was also viewed as a provider in the community, so they knew me. We already had a relationship, and so it worked well when I came to their offices. We also learned that changing office practices is really a process, and it curves over time. It's not going to happen right away, so we just can't push it. We have to be patient. We found that offering advice, support, and resources was helpful, but we also had to allow the offices to figure out how to implement their own changes. It really had to be their ideas, how to make changes in their offices. They had to figure it out and embrace their own plan. We also found that we really needed an office champion to secure the buy-in of the other providers in the practice. So we were able to identify and champion in each of these 3 offices. We learned that we were most successful when we framed chlamydia screening as part of the other primary care services being offered. And, all the providers understood that, they had to ask all these, health behaviors, and so this is a tool that helped them do all of it. If we just asked them to ask questions around sexual health, I don't think they really would have been excited about it. Also, the peer-to-peer role modeling was really influential. So the suburban rural office was reluctant to start chlamydia screening because they feel that they would offend their parents and the patients, and only once they learned that the other offices did not encounter any negative feedback and were routinely screening that they decided to start chlamydia screening themselves. So what are our next steps? So we are going to expand our chlamydia screening QI project. We're going to partner with the local health plans to work with their primary care networks. Chlamydia screening 15 to 25-year-olds for females is a HEDIS measure, so the health plans really want to see improvement in this area. And the health plans have the ability also to incentivize the primary care offices, which helps a great deal. And we're also partnering with the New York State Department of Health and the New York City STD HIV Prevention Training Center. So we're going to have a lot of resources, I hope. So that's all I have to say, and my time is up, so I will turn it over to questions. Thank you.
Great. Well, thank you. A great presentation, Dr. Burstein. Maria, want to remind people again how they can ask a question?
Sure. Once again, you can type in your questions on the chat box in the web room, or alternatively, press #1 on your phone keypad. Thanks very much.
So maybe I'll start by asking a question, and in part it follows up on the first presentation by Miss English, and that had to do with ways of thinking about how to protect some of the confidentiality. Clearly, having everybody tested is one way, but you had referenced that you might be working with the clinicians around which CPT code to use. I wondered if that part of that discussion was whether or not to bill a certain way so that it might not disclose what the treatment was for, what a visit was for, versus another way.
Right. Well, there are a couple issues. First of all, again, and informing parents that there was going to be a chlamydia test, set them up to expect it for everybody, and then if they didn't end up sending a chlamydia test because the patient didn't disclose they were sexually active and it didn't appear on their EOB, I mean, the parents didn't really question it. So we found that, actually a good strategy to enhance confidentiality is through full disclosure, that letting them know they're going to be ordering this test. So also now with healthcare reform, we're actually researching with our local health plans the CPT code to use for chlamydia screening, where it will be first dollar covered, so that there won't be any co-payments, and there won't be any financial responsibility on the primary insured. So in New York State, this theoretically doesn't need to appear on the explanation of benefits. So, again, just, trying to figure that out. Ultimately, if an adolescent feels, for their own personal safety or sanity that there's absolutely, no way that their parent can have any knowledge that they were engaging in sexual behaviors or they had an STD test, we encourage providers to refer their patients to a Title X family planning clinic.
Great. Thank you very much. So one question that has come in from a participant in the webinar is whether or not you have more recent results from after your follow-up visit, and in particular, did the mid-size office chlamydia screening rate increase after that 6-month visit?
Right. Well, I did this project through a National Chlamydia Coalition grant. It was only $10K, and most of that went to those bubble sheets. So I was only able to do the study for 6 months. But about a year after we finished the study, the groups got together and we did grand rounds at our children's hospital. And I was really surprised to hear that all the groups were still using the tools, and this mid-size office was telling people they made systems changes to improve chlamydia screening, and they're now routinely chlamydia screening all their sexually active adolescents. And I couldn't believe my ears. But again, I don't have any hard data to look at that now, but again, that's just anecdotal reporting from the providers. But hopefully with this next round of QI projects, partnering with the health plans and all the offices have EMRs, it will be more easily able to obtain those data and see how they're really doing.
That's great. Well, that's encouraging to hear. Maria, any calls waiting to ask questions?
None over the phone lines, John.
Okay. So let me ask other questions that are coming in writing. One question asks, what strategies you recommend for approaching practices when you want to encourage them to participate in these type of QI projects and they might initially be reluctant?
Sure. I mean, QI projects can be very painful. Most provider offices don't really want to take it on if they don't have to. So that's why with this go around, I thought it would be most advantageous to work through the health plan, so the health plans could encourage their primary care network offices to take on this as a QI project. I mean, it's a win-win situation. Chlamydia screening, and we're also going to look at HPV immunization rates among 11, 12-year-olds. I mean, those are both HEDIS measures. The health plans are, incentivized to make sure that their offices do well with those, and so they can incentivize the offices to take on the QI projects. So, I mean, that's, we're all, now that with a strategy with healthcare reform is population-based health. So I think chlamydia screening and HPV immunization intersects with that. Chlamydia is is our number one reportable communicable disease. HPV is our number one non-reportable communicable disease. We're all supposed to be working on population-based health. So I think this is an opportunity where we can all intersect and take advantage of the opportunity to work with health plans to do a QI project.
That's great. Thank you. A follow-up question came in from another participant asking what your thoughts are about the feasibility of the American Academy of Pediatrics having a provider-targeted webinar that perhaps covered some of the same approaches that you've talked about.
Sure. Well, that's a great idea, and actually that's another strategy that we have been using in New York State. We have, I learned, being both a pediatrician and working in public health, that pediatricians, they really receive their recommendations for a clinical practice from the American Academy of Pediatrics rather than CDC. Even for STD management, they look at the American Academy of Pediatrics Red Book recommendations rather than CDC's STD treatment guidelines website. So we tried to take advantage of that. We worked with the New York City STD HIV Prevention Training Center to collaborate with our New York State American Academy of Pediatric District to host a series of 5 webinars on sexual health. So what the pediatricians saw is these are AAP webinars, and AAP recommending how to practice for sexual health, when it was, really behind the scenes, public health was driving it and making sure the information was getting out there. So, I encourage, people in, state and local health departments to really reach out to the medical professional organizations, the providers that they're trying to target. For us, where we are in New York State, we know that many adolescents that access the healthcare system still go to their pediatricians. So we tried hard to target pediatricians, but so we worked with the American Academy of Pediatrics, but there's, ACOG, the American College of Obstetrics and Gynecology, there's the American Academy of Family Physicians. So again, establishing those relationships and so, having the message, the public health message, come from those professional medical organizations, I think will draw more attention from the community providers that we really need to, target to, improve their sexual health care delivery practices.
Terrific. Thank you. I know that a question that will come up is if others are interested in seeing a copy or having a copy of the health risk survey, is that something that could be made available to others?
Sure. Of course. I believe that is on the American Academy of Pediatrics website. I think it's going on the New York City STD HIV Prevention's website, but I can also send it to ASTHO, and it can be on your website too.
Terrific. Thank you very much. Maria, are there any remaining calls on the telephone?
None at the moment, John.
Okay. Well, again, thank you very much, Dr. Burstein. A terrific presentation and a great example of the way to offer chlamydia screening services to adolescents.
Thank you.
So with that, we will be bringing the webinar to a close. Let me offer again my thanks to ASTHO and especially to CDC and the leadership of Dan Lantini, who has supported this effort. I want to also thank Kristen Golden, who's worked at the Institute on Urban Health Research and Practice to organize these two webinars. We look forward to continuing to work with the partners that I'd mentioned at the beginning of the webinar who have taken a leadership role in providing assistance and thinking about the efforts to integrate STD services into primary care and to link public health to primary care, community health centers, and other sites. Thanks to all of you who have participated, and at this point we will bring the webinar to a close.
Recording stopped.